Hello, we are here to discuss our DNP project over dexmedetomidine and want to express our appreciation of your participation. Our project is composed of two phases. In phase 1, we are evaluating provider knowledge and perceptions over dexmedetomidine and providing this educational intervention. In phase 2, we will be completing retrospective chart reviews to see if patients who received Precedex intraoperatively had fewer PACU complications, such as decreased pain scores, opioid consumption, rescue antiemetic need, and PACU length of stay. We will distribute this data to all IURNet anesthesia providers at the conclusion of our project. We understand that much of this information presented will not be new information to you and will serve as a brief review on dexmedetomidine.
Dexmedetomidine is a highly selective, very potent alpha-2 adrenergic agonist. Alpha-2 receptors are found in both the central and peripheral nervous system, with a very dense presence in the pontine locus ceruleus. This area of the body plays a significant role in a person's vigilance, likely leading to the sedative effects of dexmedetomidine. Patients who receive dexmedetomidine can be easily aroused because the medication works by decreasing sympathetic nervous system activity compared to drugs that act on GABA receptors that produce a clouding of consciousness. Clonidine is also an alpha-2 adrenergic agonist, but compared to dexmedetomidine, it is 7 to 10 times less selective. For this reason, dexmedetomidine is considered a full agonist and clonidine is a partial agonist. Medetomidine is composed of two optical isomers, with the active isomer being dexmedetomidine. This medication produces similar effects of dexmedetomidine and is currently only used in veterinary practice.
The half-life of Precedex is 2 to 3 hours, which is less than half the duration of clonidine. Precedex is highly protein-bound, with more than 90% of the medication bound. Precedex undergoes hepatic metabolism and results in two conjugates, methyl and glucuronide, which are then excreted by the kidneys. Common ways to use Precedex intraoperatively include incremental IV pushes or loading dose followed by an infusion dose. The recommended doses are a maximum of 0.5 micrograms per kilogram for IV push, typically given in 2 to 4 microgram doses, a loading dose of 1 microgram per kilogram over 10 minutes, and an infusion dose of 0.2 to 0.7 micrograms per kilogram per hour. Currently, there is no reversal for Precedex. Atipamezole is an alpha-2 antagonist that reverses sedative and cardiovascular effects of Precedex, but is currently only used as an emergency drug for zoo and wildlife animals. Administration of Precedex produces many effects on the body. CNS effects include producing sedation that mimics natural sleep without interfering with electrophysiologic monitoring. This makes Precedex a good choice during procedures that utilize neuromonitoring, such as awake craniotomies. Additionally, Precedex does not have an effect on cerebral metabolism, but does lead to a slight increase in cerebral blood flow, creating an uncoupled effect. Hypotension and bradycardia may be seen due to systemic vasodilation. Additionally, transient hypertension may occur with a rapid loading dose or too high of a continuous infusion due to peripheral vasoconstriction. One advantage of Precedex is that respirations are maintained even at supratherapeutic plasma concentrations of 14.9 nanograms per milliliter. Precedex is also beneficial in patients with acute lung injury by inhibiting reactive oxidative species from generating. This allows for rapid increases in lung alveolar epithelial cells and promotes cell survival. Lastly, Precedex is a mild diuretic due to alpha-2 receptor stimulation as well as an antisalagogue.
It has been shown that dexmedetomidine contributes to superior pain control and higher patient satisfaction in both laparoscopic and open procedures. Some procedures that may benefit greatly from intraoperative dexmedetomidine administration include bariatric, gynecologic, colorectal, neuroskeletal, and abdominal procedures. During our literature review, we found that 77% of studies proved that dexmedetomidine given intraoperatively led to a significant reduction in pain scores, and 60% of the studies found that opioid consumption was significantly lower when using Precedex as an adjunct. Precedex can be a great adjunct for obese patients due to the ability to use less volatile anesthetic, less opioids, and less antiemetics. This can lead to lower postoperative pulmonary complications. Additionally, Precedex should be dosed on total body weight, even in the obese population. Precedex is also a good option for patients at risk for postoperative agitation and delirium, such as the elderly, over 65 years old, pediatric patients, and younger adults. Patients with a history of chronic alcohol or drug abuse are also at an increased risk of postoperative delirium and agitation. Finally, high-risk procedures such as cardiac surgery, orthopedic surgery, and major abdominal surgery are associated with increased rates of delirium.
Special populations include pregnant or nursing mothers, as well as the pediatric population. For pregnant and nursing mothers, there are no well-controlled studies performed, but there are some case reports of utilizing Precedex in parturients when anesthesia providers determined benefit outweighed risk. Precedex does cross the placenta, but a high fraction of the drug is retained in the placenta and does not cross to the fetus. This is supported by 5 case reports where parturients were given Precedex and all fetal APGAR scores at 1 and 5 minutes were within the normal range. In the literature review disseminating this information, there were no reports of parturients who received Precedex and had inadequate APGAR scores. Precedex can be traced in breast milk in very small amounts for 4 to 6 hours following infusion of the drug. By 24 hours post-infusion, there is no Precedex found in breast milk. Because of the low dose in breast milk and limited oral bioavailability, the effect on the infant is expected to be minimal. For pediatric patients, Precedex is known to reduce emergence delirium. In one study of 288 pediatric patients, they found that 37% of patients received post-operative emergence delirium when not receiving Precedex, compared to 17% of patients who received Precedex for general anesthetic cases. A second study of 80 patients compared Versed to Precedex for MRI sedation. They found that a dexmedetomidine infusion provided better procedural sedation compared to midazolam, with 80% of patients needing rescue sedation from the midazolam group, while only 20% needing rescue sedation from the Precedex group.
Some common misconceptions regarding Precedex include the thought that Precedex will increase the time in the PACU due to oversedation, when in reality the literature showed that majority of the time length of stay does not differ between patients who did and did not receive Precedex, and 38% of the time patients actually had a decreased length of stay. Additionally, the context-sensitive half-time of Precedex is approximately 4 minutes after a 10-minute infusion, and clearance matures with age. However, it is reduced by 27% after cardiac surgery. Another common misconception is that Precedex will cause hypotension and bradycardia in all patients. While these may occur due to the alpha-2-mediated vasoconstriction, which leads to baroreceptor-mediated bradycardia and increased vagal activity, it is more likely in elderly patients when given doses higher than 0.7 micrograms per kg. On the other hand, a high-dose rapid bolus can result in transient hypertension. Lastly, many times Precedex is given as a bolus and thought to have an immediate onset, but the onset actually takes at least 5 to 10 minutes with a peak effect in 15 to 30 minutes. Below are our references. Thank you for listening.